Hello, everyone, and welcome to today's industry webinar, QPP Year 2. My name is Alex Goulding. I'm the Marketing Manager here at Azalea Health and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using their computer audio system by default. If you'd prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's presentation. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any peers. I'd now like to introduce Michelle Bose. Michelle has more than 20 years of hands-on work experience in hospitals, clinics, imaging centers, medical consulting firms, and billing companies, both on the clinical and the administrative spectrum. She's a trusted colleague of the Colorado State Office of Rural Health and helped anchor one of the most successful regional extension center programs in the nation from 2010 to 2015. Michelle has assisted with several hundred eligible providers and nearly 100 hospital and critical access hospital immunoattestations over the years. The deviation from the EHR incentive program to quality payment program has forced everyone to shift gears, and naturally Michelle has embraced the challenge of establishing herself as an expert in the new era of value-based reimbursement. Michelle joined the Azalea Health team in 2015 as the CMS Regulatory Program Compliance Team Lead Consultant. She works closely with development to support the 2015 ONC certification and red tape requirements, as well as with clients to provide expertise, insight, and support. With that, let me turn today's presentation over to you, Michelle.
Thank you, Alex. Hi, everyone. Let me get us to the next slide. Okay. So thank you for joining. We're very excited to have everybody with us today. We have a lot to cover, so I'm going to go ahead and jump right in and talk about where we are today. So we are in the 2017 QPP performance year, and it is submission time. The QPP website has been accepting submissions since January 2nd with the final deadline of March 31st. Now that might freak some of you out, but don't freak out. If you've not done anything to prepare yet, it's not too late to start. You can still do something to avoid the negative payment adjustment. So there are two ways of participating in the QPP program. The first of which is the MIPS track. And as we all know, the MIPS track has 4 categories, each with their own weight toward a composite MIPS score. Those categories are quality, ACI, improvement activities, and costs. You do have the option of submitting as a group under a single tax ID or individually as eligible clinicians. They do allow you to submit minimum test data in order to avoid the negative adjustment. And what that means is you could submit a single patient on a single day via a claim for a single CQM, and that will make sure that you are not penalized in 2019. Now, if you are planning to participate in MIPS, again, the deadline for attestation is March 31st. So we do have a couple more months to get submissions completed. The next track is the alternative payment model. If you are in an APM, you already know it. You've been participating probably much of the year, getting interfaces set up, understanding what your particular APM needs. We just feel it's important to explain that there are differences in APMs. There's a MIPS APM and an advanced APM, and there are major differences between the two. Just very quickly, MIPS APM has the same requirements as if you were submitting to MIPS yourself, but the scoring is a bit different. All categories are required to be submitted, but the MIPS APM may only be aggregating and submitting specific categories on your behalf. So it's very important that if you're working with a MIPS APM, that you get clarity on what they're claiming responsibility for and what you are responsible for as far as data submission. Also within MIPS APM, there is no bonus given for participation like the Advanced APM. The Advanced APM path is for providers who go the furthest in delivering high quality, coordinated and efficient care. There's also some shared risk involved. So let's talk a little bit more about the Advanced APM participation very quickly. So CMS is pushing hard toward Advanced APM participation. They predicted about 100,000 Part B clinicians would participate in 2017, and they're estimating 185 to about 250,000 in 2018. So that almost doubles, or more than doubles, depending on if they hit the 250,000 mark. With the Advanced APMs, you earn an annual excuse me, an annual 5% Part B incentive. You are exempt from MIPS. In 2026, the QPs for the Advanced APM will accrue a higher level Part B Medicare physician fee schedule. And the QP status for those Advanced APMs is determined by 3 performance year-to-date snapshots for Part B claims that end on March 31st, June 30th, and August 31st. And in return, participants must receive a certain percentage of their Medicare Part B payments or see a certain percentage of patients through an Advanced APM. Again, like I said, CMS is pushing really hard toward participation in these. Just be sure to weigh your participation options. Make sure that's a good fit for you. You know, sometimes submitting the MIPS track seems a bit daunting to do it on your own, but you know, it's individual. It's what is going to be the best for you as a practitioner or for your practice. So going back to MIPS, again, with the 4 categories, advancing care information is one of those categories that's required to be submitted. Now, CMS has offered not a hardship, it's actually a reweighting. So what that means is that you would reweight the score that you would get from your ACI category over to your quality category. So if you are reweighting your ACI category over to quality, some eligible clinicians have that done automatically, and some must submit an application. The special status clinicians have their reweighting done automatically. However, that does not mean that you cannot submit ACI if you have that available. You could still certainly submit that, but the list on the screen does count all the different eligible clinician types that have their ACI reweighted. Please note that the second to last bullet, the ambulatory surgical center based eligible clinicians are automatically reweighted, and that was a result of the 2018 QPP final rule that came out just a couple months ago, and that did go back to the 2017 transition period year, which is the one we will be submitting to shortly if you've not already. So there are several different ways to submit to MIPS for 2017. I feel it's important that you know that you can submit categories separately through different submission methods. However, each item within the category has to be submitted the same way. So let's talk about the different submission methods. Electronically will earn you a bonus for end-to-end electronic submission. And you can do that several different ways. You can do that through your EHR, who has your EHR vendor might have a API to CMS to submit a category or two or all of them on your behalf. You could submit electronically also through a registry or a QCDR. Those always come at a cost. If that's something you're interested in doing, that's something you're probably already set up and have been monitoring. I know that most registries and QCDRs cut the onboarding time at last year it was November, just because there is quite a bit of a process to get folks onboarded. The other two options are, of course, manually through the Quality Payment Program website and via claims. So we know a lot of folks are submitting manually through the QPP website. There are quite a few vendors who have the interface to CMS up and running to be able to submit either the quality category or all categories electronically, but a lot of the vendors don't. And with a lot of folks, the registries just don't make sense. They're really more for specialty, larger groups, those types of folks. So if you are planning to submit your MIPS categories manually, it will be done through the Quality Payment Program website, and that does require your EIDM account. So if you are familiar with PQRS, if you've submitted in the past, excuse me, you probably already have an EIDM account. If this seems like a new concept to you, you don't really know what EIDM is, this is something you're going to want to go get set up right now. It does require quite a bit of personal information in order to verify your identity. And it is required before you can even go over to the QPP website and log in. Okay, so if anyone has questions about submission to the QPP for the MIPS track for 2017, I know I went through that really quickly. There's a lot of information to gather, of course. There's a lot of information to learn as we migrate to the new QPP website and a new attestation. A lot of you are probably familiar with the EHR incentive submission web pages, PQRS pages. This is a whole new thing. So if you need any help with that, please don't hesitate to reach out to us and we'll help you walk through that. Okay, moving on to 2018. So in 2017, it was all about learning. We were learning the program, we were learning how to document, we were learning our EHR system. You know, how is it extracting information? How is it reporting? How do we submit? So it was all a learning game. In 2018, we're going to take what we learned and we're going to apply it. We're going to think about strategy. We're going to focus on improvement, and we're going to try and maximize our participation in order to hopefully get more money. So there are a couple things that I just want to talk about. I feel like this year has been just a scramble. We just want to get there. We want to cross the line. We want to avoid the penalty. But now we're stepping into 2018 knowing what we know. I think strategy is an important place to start. And that starts with thinking about if you should participate as an individual again, or would a group participation like rocket launch your payment adjustment. Perhaps you should evaluate participation in a MIPS APM or an advanced APM. What are the pros and cons? What are available to you? Also, does a virtual group make sense for you? This is something new for 2018 that we'll touch upon a little bit later. Also, if you're a specialist, would it make more sense for you to partner with a registry or a QCDR who offers ECQMs that may apply more appropriately to your specialty? A lot of the EHR specific quality measures are primary care focus. And a lot of specialists would do better with the registry. Focus on improvement. So if you don't have an EHR, maybe you should consider it now. Sure, the EHR incentive funds are a thing of the past, but vendors are still offering incredible financial options these days. It could be that the money you reap in 2020 would be enough to cover your costs. And if you already have an EHR, dig into that documentation and the workflows for the ACI objectives and for the ECQMs that make most sense for your practice, your specialty, and your submission method. This is really key to improvement. Another key point, do not assume that you know where to document. These EHRs are smart and they're built to easily be able to collect, aggregate, and report data. And that being said, documentation has to occur in a specific way and in specific fields. So lean on your EHR vendor to supply you with documentation. They have it and they want you to use it. Also, pick your CQMs and pick your practice improvement activities early in the year. Focus on improvement over last year's efforts. And for quality, improvement in the category will result in a 10% bonus of the quality score. So that's major. Lastly, dig in with your entire organization. This includes your admin, your medical staff, clinical staff, IT, quality, HIM, lab, you name it. To win in the regulatory program game, you have to have organizational inclusion and buy-in, goal-oriented leadership, and managed workflow training for all levels of staff. It really, really, really is a team effort. All right, so there were a couple of 2018 QPP final rule effects on 2017, and those were exclusions were added. So low volume exclusions for eligible clinicians for the health information exchange objective and the ERX objective were added. So those retroed back to 2017. Also, again, we touched on this earlier, the automatic reweighting for ACI for those eligible clinicians in an ambulatory surgical center was implemented. All right, so let's talk about the changes in the 2018 QPP. So there were changes in the penalties and incentives. It used to be 4% in 2017. The max penalty and incentive in 2018 is 5%. And of course, this would be applied in 2020. The categories are a little bit different in 2018. So quality shifted down to 50%. ACI is staying the same at 25%. Practice improvement is at 25%, and cost is at 10%. And again, these categories contribute to the overall MIPS score. And of course, cost for 2018 is new. All right, there are also new low volume exclusions in 2018. So these have increased over 2017. Up to $90,000 for Medicare Part B, and then 200 patients or less. If you don't know how to check your eligibility to see if you meet these low volume exclusions, all you need to do is go to the QPP website, qpp.cms.gov, and that website will tell you if you're eligible individually or as a group. If you're not eligible individually or as a group, it means that you've met one of these low volume thresholds. Also, they've added more relief for small practices. If you don't somehow meet the low volume thresholds in a small practice, you still get special treatment. There are bonus points added for final scores, lower practice improvement requirements, the ability to join virtual groups, hardship exemptions for the ACI, meaning that's the reweighting application, and also credit for quality measures submitted below data completeness standards. All right. In 2018, the MIPS performance threshold increased from 3 to 15. So that means you can no longer just submit something to avoid the negative adjustment. Whatever you do submit has to have a minimum performance threshold of 15. That could be maybe 2 quality measures. You know, it just is a little bit more complex than it was in 2017. They've also added bonuses for complex patients, up to 5 bonus points available to recognized clinicians who treat complex populations. And this is based on a combination of the HCCs and the the dual eligible population treated. The data completeness threshold increases to 60. So for the quality category, eligible clinicians or groups must submit data on at least 60% of applicable Medicare Part B patients seen during the performance period for which the measure applies. This is up 10% from what it was in 2017. Technology requirements have shifted quite a bit. Eligible clinicians or groups may either use 2014 or 2015 certified electronic health technology or a combination of both. They've done this because the quote unquote stage 3 objectives are no longer required in 2018. And so they've relaxed this just a little bit to include the modified stage 2 objectives if folks want to report on those for ACI. Also, excuse me, the APMs are expanding to all payer models in 2018, and fewer participants are expected to submit to MIPS. They're expecting a shift toward the APMs in 2018. Improvement scoring is something new. So for quality, improvements in the category as a whole will result in 10% of the quality score. And for cost, improvement analysis occurs at the measure level for an earning potential of up to 1% bonus in the cost category. And if you've read the final rule, this is a bit of complex math, and we could certainly get into that in future white papers or webinars. That is something new for 2018. All right, and again, kind of the highlights of what's new. So the 15-point minimum threshold to avoid the negative adjustment. So again, no longer just submitting something. You do have to submit a couple of good data elements in order to avoid the negative adjustment. The exceptional performance threshold is again 70 points of the MIP, or I'm sorry, 70-point MIP score. That really isn't a change from 2017, but the payment adjustment of plus or minus 5% is new for 2018. All right, so digging into a few of the brand new concepts for 2018 QPP. The first one is the virtual group. Virtual groups, again, a new concept where clinicians can come together to join a group and submit kind of as like a clinic group would. But there's no boundaries. So the virtual group needs to be comprised of at least 2 tax IDs who would then aggregate the participants' data to submit to MIPS as a single identity. Why would you want to participate in a virtual group? Perhaps an eligible clinician needs support from others who are a bit more MIPS savvy, who have really dug into the program, who can kind of guide other clinicians. Perhaps you're not ready to join an APM yet, but you want to remain independent and want to band together for reporting purposes to be more successful under MIPS. The virtual groups really no geographical or specialty boundary. This is really unique to me. So that means, let's say you have 5 different primary care practices across the Midwest. You don't have to be in the same state. Really no relation between you at all, except for the fact that you've met and you really feel like you have a synergistic energy and you want to come together to report to MIPS as a virtual group. You absolutely can do that. There is a specific election process for forming a virtual group that includes identification and collaborative agreements that must be in place. And those elections have to happen before December 31st of each year. There is a virtual group toolkit out there to get started that CMS has put together. So if you're interested in that at all, we can share the link for you or with you, and try and help you understand a little bit more about the virtual groups. All right, so we talked about improvement scoring just a bit. In 2018, the improvement scoring, of course, gives bonus percentage points to those who demonstrate improvement in quality and cost. And of course, the reweighting exceptions are still available. The 2018 reweighting was revised a bit to include hospital-based eligible clinicians that are in place of service 19. And of course, the ASC-based eligible clinicians are automatically reweighted as well. One other thing that I feel like it's important to note is the applications for hardships are now limited to a 5-year span. So if this is something that you're planning to submit a hardship for the entire program, there is now a limit to 5 years for these. And that actually does apply to hospitals as well under the Meaningful Use Program. So just keep that in mind. All right, the cost category is technically not new, but there was a zero weight in 2017. So for 2018, the weight of the cost category is 10% of the total MIPS score, and that jumps to 30% in 2019. There's really nothing that you need to do for this category. It's automatically calculated by CMS based on your Medicare spending per beneficiary and total per capita cost measures. The condition treatment episode-based measures actually is a typo that should not be there. That was actually removed for the 2018 cost category, but that is something new. And that actually takes us to the end of what's new for 2018. So Alex, I think I'm going to hand it back over to you.
Thank you, Michelle. We're now going to begin answering questions submitted during today's presentation. As a reminder, you can still submit questions in the question pane. So let's go ahead and jump in. Our first question says, if we have both a specialty clinic and primary care billing under the same TIN and are submitting under the group TIN, can we pick specialty quality measures for the specialty physicians and the more traditional or general quality measures for the primary care physicians?
Okay, so if I understand correctly, we've got a specialty and a primary care, and they're asking if they can select different quality measures for different parts of the group.
Yeah, under the same group 10. Mm-hmm.
Okay, so no. If you're submitting as a group, you're going to submit your quality measures, your 6, and then if you want to submit additional for bonuses, you sure can. But if you are selecting your 6 quality measures, those 6 would represent the group as a whole. This is where some of that strategy comes into play. So if you have 6 quality measures that are more specialty related, though your volume might be lower, but you are at a higher percentage for those quality measures, as long as you're meeting the requirements for data completeness, you can absolutely use those and apply them you can apply them as the entire group. You're not able to split them up.
Perfect. So along those same lines, and I think you addressed this a little bit, but if you can maybe expand a little bit more, the next question asks, I'm a specialist and most of the ECQMs that my EHR offers are too primary care specific. Should I consider a registry?
Absolutely. Absolutely. Of course, reach out to several different registries, get quotes from them. They have seemed to come down in price quite a bit from the beginning of the year, but they also offer so many more quality measures than what the EHR can offer. And I'm not quite sure why CMS set it up like that. I think registries are just a little bit more agile in their ability to collect and update quality measures, but absolutely, there's a lot more for you through a registry.
Great. Next question says, can Azalea help support MIPS participation efforts?
Absolutely, absolutely. You know, we offer professional services to everyone, and these services absolutely include any of the regulatory programs as well as hospital programs, and you know, there's a long list. So we can absolutely help you navigate the MIPS maze here.
All right. We are at the top of our time, so I'm going to go ahead and conclude today's webinar. I do want to note that questions submitted that we did not have time to get to will be addressed following today's call. So thank you, Michelle, and a special thank you for everyone taking the time to attend today's webinar, QPP Year 2. And as a reminder, Michelle's slides will be shared in a follow-up email, and we'll also include a link to review the recording of the webinar in case you want to review again later or share with any peers. Thank you.
Thank you.